Great. Good afternoon, everyone, and welcome to our noon meeting for today. On behalf of the head of the department, Professor Landemeyer, I welcome all of you to this noon meeting. Today we have two distinguished individuals who will be speaking to us about contracting private sector during this COVID pandemic. As we all know that the public sector is not sufficient to be able to handle everything. So contracting of private sector is a really important part. I know the two individuals here are not new to us. They don't need introduction, but for those who do not know them, I'm happy to introduce them one after the other. In no order in terms of one being higher than the other per se. I will introduce them as the names appear on the screen there. First, we have Beth Engelbrecht, who is now an emeritus head of health within the Western Cape Health Department. She's also an honorary associate professor within the School of Public Health and Family Medicine, and a faculty member at the Institute for Healthcare Improvement. The Institute for Healthcare Improvement is an NGO based in Boston, Massachusetts, in the US, with global footprint. Next, we have Dr. Bhavna Patel, who again is not a stranger to many. She's currently the CEO of the Provincial Hospital here in the Western Cape as part of the Western Cape Department of Health. I could do more than this, but in the interest of time, I would let that be, and I hope I have not kind of condensed them into just a sentence. So without further delay, I would like to give the floor to, I don't know who's going to go first, Beth, Dr. Engelbrecht or Dr. Patel, whoever goes first. The floor is yours. Thanks.
Thank you very much, John. Thank you for that introduction. And thank you for everybody participating and hearing to our input today. So I will do kind of the presentation, and Bhavna will also contribute a few particular slides. And on the screen, we've got there also acknowledgements to Gitesh and Jude and Michael Manning for their inputs in this presentation. So we are also the team doing a chapter for the South African Health Review on contracting the private sector. And today will be, I think the discussion will also contribute to some of the insights that we need to include in the chapter. So during COVID, since my term ended at the end of March, Keith Critty, as the new head of department, asked me to just stay on for about 6 months. And my main job was during the COVID period to do all the intersectoral connections, and then the private sector has been one of them, which put me in a position to kind of play a leading role in this initiative. So we can go to the next slide, and which talks about, so Gitesh is managing the slides. Thank you, Gitesh. Okay. So people are very aware of the modelling consortium that made forecasts early in 2020 and indicated the available acute ICU capacity, but they very clearly indicated it would likely be overwhelmed by increasing demand due to COVID-19. And I will come to a bit more details on that a bit later. It was then very obvious that if we are serious about protecting the public sector, staff and facilities, but also try to be the best we can for the community we serve, we will most likely have to contract with the private sector. And that was one of the range of options for addressing the expected capacity shortfall. So in the presentation, we looked at the rationale for contracting the private sector, the ethical considerations, and then also governance in this approach. And obviously, all of this what is the relevance of this learning and this experience for the future in South Africa? Thank you. Next slide, Kitesh. So just to take a step back, the COVID-19 care continuum had various segments. The top one covered in blue here is the suppression and containment. Now that is part of prevention. That's community prevention, screening, testing, contact tracing, isolation, quarantining. That is where most of the energy had to go to make sure that we protect the system as best we could. The orange block is the mitigation, and that is where in our primary healthcare settings, acute hospitals, palliative care, that is where the mitigation was, and this is also the focus of this, to say that for acute hospitalization, especially where critical care is needed, what was our journey, and then the recovery thereafter, and then if patients had adverse outcomes, then how do we deal with mortgage? So each of these components of the care continuum had a particular strategy and a forecasting model that supported the decision making around that. Thanks, Kitesh. Next slide. So this slide, you can see that it was done in May last year. That was done by the National Department of Health. And if you look at the various, to the left is the various provinces, and then the current capacity, the projected peak demand, mild options, inpatients and critical care options. So those are the broad columns in the slide. So the current capacity spoke about the total capacity of facilities, whether it's maternity care, pediatric care, adult care. It was just the total capacity. And then the projected peak demand came from the forecasting that was done to say that if you forecast what's going to be the demand only from a COVID perspective, and then for the country it was nearly 30,000 beds for ICU, if we just look at that column, and then for the Western Cape was 3,900 beds. Then, and if you look at the capacity with all the critical care beds in this province, public and private together, it was 1,000. So clearly a big shortfall. Then the forecasting teams looked at what could be the options that we look at, because clearly to prepare for 3,900 beds, which is nearly 4 times what we've got, really. And for a limited period. At the time, we were just preparing for one peak. And so they looked at the 5% of mild cases, temporary mass facilitation, isolation facilities, 1%, and then from an inpatient, what would be the shortfall. If you look at the very far right column on the critical care options, and then you can see the middle column there is 10% of the projected ICU demand. So in the Western Cape, the ICU demand for COVID was 3,900, and then 10% of that is then 392. That was the demand what we had. But the actual deficit on that 10% was then 636 beds, which was the actual deficit that we've had. In the Western Cape in March, we already had a projection based on, because we were the epicenter of the epidemic, and at the time we already showed that we would need, well, depending on the option, on the scenario, between 200 and 4,000 critical care beds, and clearly it was a very difficult space to plan in, because it was so uncertain, and there were too few data points to make a more clear prediction. But that is what we sat with. The bottom line is we knew we had to few, and we have to put out all stops to be able to obtain more capacity in one way or another. The next slide. Then that slide just shows the numbers. Sorry for that. Yeah, okay. Then, so the options that we had was how to expand capacity beyond de-escalation. So the option was, don't do anything, just hope and pray for the best, or expand capacity in the existing facilities, or build additional temporary capacity. And clearly that is more useful for your acute care, but not where you need ventilation or critical care. And then insourcing by contracting with the private sector. So there were many options, considerations in selecting which option to follow. Clearly, politically, there was a lot of pressure, and suddenly ventilators became the the badge of honor. If you've got more ventilators than another province, or if the politician can say they're getting so many ventilators, that became something that was heralded as the be-all and end-all. But also politically, from the national minister's side, the Western Cape being the epicenter, what are you doing? Why are you not moving fast enough? So there was a lot of pressure for us to make sure that we can be as best as we could. Planning and implementation capacity, countrywide, it's not the same across the country. And I must say, in the Western Cape, we had of the best modelers, forecasters in the country, and they were with the strategic team to sort out how do we approach this, what is their best forecast based on international trends as well as locally, and how to plan. And then also from an implementation side, how do we look at what capacity is required for implementation. Lead times, clearly to staff and equipment has been the biggest, the most critical capacity that we set with, and lead times to get that. If you want to do infrastructure changes, that's even longer. And from the private sector side, their argument was, if we invest in more critical care beds, you will carry that, and what will we do with the investment after the time, because we're only preparing for one peak, it's about 4 months. So all of these came into play. And then obviously, to what extent can be as flexible as possible, and how can we contain costs as best as possible, given the fact that most investment has to go into the preventive care, into treating acute cases, but clearly the outcome, the mortality figures for critical care was not good at the time. And do you invest more there, or how do you approach it? How do you balance that reality? The next slide, is then the approaches that we have adopted. So both national and provincial, they were really exploring what is the possibilities to be done. Michael Manning, who is also in this call, together with his connection with the private sector, put a survey out and say, how many beds can you make available? Clearly, you have to also care for non-COVID patients. How many beds can you make available? Are you willing to work with the public sector? Will you be able to contact with us and explore that? And we know that at the national level, especially Nicholas Crisp was very much instrumental in connecting with the private colleagues and see what is possible from that level. And then between the province and national, we also try to remain connected in the progress in this field. Yet there was little coordination across the different initiatives. Not everybody was invited to sit around all tables. What happened in the Western Cape, because of the epicenter here, there was no pressure in, for example, Limpopo at the time. So it was not, there was not coordination across the whole country. And there were also different levels of capabilities across the various provinces, and especially in the relationships with the private sector. So there was not that good coordination across the various initiatives. So ultimately, in our province, we had a combination of various approaches. Firstly, to de-escalate, and the de-escalation was to really make sure that we can make available as most capacity for COVID patients as possible, yet to keep balance with the need for non-COVID patients, and trying to find the best balance. And that was really a hands-on. There's no There's no golden formula that we could use. It was really just to say that let us manage it as it happens, be responsive, responding as best as we can. So the de-escalation was a particular issue. It was very difficult, especially for some of our surgical colleagues who then had to give up critical care space and surgical procedures because the critical care areas had to be protected. Then expand capacity in the existing facilities with inpatient and critical care. That happened in both public and private. What we did, that we are, as a province, responsible to license private facilities, and each and every bed that they have in the hospitals must be licensed, and that is part of the legislation. So in March already, we got the MEC to indicate to the private sector that we will waive the requirement for licensing, and they must just respond with the type of care that's required for the burden of patients that will come our way. The further aspect was also built additional temporary inpatient care capacity, and the CTICC, the Hospital of Brackengate were additional inpatient care capacity that was built in our province and across other provinces. I think all provinces just moved very fast on this. Some people refer to that as field hospitals, but they were much beyond field hospitals. We realized that the patients that went there were more ill than initially predicted. But in record time, it was possible to expand capacity, and especially also with high flow oxygen. And then also the insourcing by the contracting of the private sector. So we developed a service level agreement, and it was ultimately endorsed by the National Minister of Health and made available to other provinces. The next slide. So the rationale for contracting with the private sector, I've touched to a large extent on that already. So what was the considerations related to the public sector? So clearly from both public and private sector side, if you look at both columns, it was a public health crisis. It was a global emergency. It was definitely also an emergency in South Africa and a public health crisis. And one can respond, one can prevent, one have to respond. Yet the challenge was that the exact demand was uncertain, both for the public sector and for the private sector. And countrywide, it was the same situation. The lead times, expansion involves infrastructure, equipment and personnel in the public sector, and sourcing requirements impacted on COVID-19 disruption. Then in the private sector, the bulk of the critical care capacity is in the private sector. And we wish to make sure that we could get access to that as best as possible, but then specifically in a fair way, that there is no differentials between public and private. The lead time was dependent on engaging and putting in place the service level agreement. So we started already in March with getting movement on a service level agreement. And I think ultimately it was in July that we could ultimately get final signatures on the dotted line. But by that time, we were already a lot of things happened, a lot of movement happened, and the relationships was built. The other aspect of flexibility was there was an uncertain time horizon for the expanded capacity. As I said, initially we thought, well, this is the peak. We expect the peak in June-ish. So that's going to be the pressure, and for how much do you prepare? How long will the patient stay in hospital? What new research will come out? So there's a lot of uncertainty, and in the private sector as well, what is their need basis? And they've got undertakings to private health insurers to make capacity available for any patient that needs. So all those trade-offs had to be considered. The costs, expanding capacity, critical care is the most expensive service area. It is expensive, but staff has been the major limitation. And again, the time horizon made it difficult to assess the return on the investment. For the private sector is that what is the capacity that we have to purchase the existing capacity? and to control it via the service level agreement and pay only for the services used. So all of those aspects had to be considered in this journey. A further slide. So the general approach was then to do the contracting. We took a decision and we also said, let's contract from a convenience contracting perspective because of all the uncertainties. Let us at least get the contract in place and then we buy what we need. But then have good governance between the parties and then very strong on ethical principles. We felt very strongly about that. We initially, together with our clinical colleagues, had critical care guidelines, which included some form of rationing. It also for the other levels. And then together with critical care guidelines, we also had palliative care to make sure that it is very clear to everybody what should be the journey. So for the contracting of the services, a service level agreement had to be drafted. For the governance, we had to have strong leadership for operational arrangements and the finances. And from the ethical perspectives, we had to have uniform principles of practice across public and private using those guidelines. So that was the general approach that we followed. The further slide. So from a public sector perspective, there's been lack of clarity on national policy on the private sector and the governance of the private sector. That's not new. That's been there for a very, very long time. Yet we had to navigate because we knew we can't wait for national. We had to move and we had to get going. There was a lack of single collective forum where the national and provincial departments engage with the private sector. And the private sector, they've got national authorities. So if you engage at the provincial level, there's always a national body that must also be consulted. There's been a lack of trust between the sectors, public and private, and also between national and provincial spheres of government. And so there is a complicated public sector supply chain process. And how do you put this out on tender? Do you have another supply chain process? And we had to navigate across all these questions. And then also that lack of systems capacity to administer a complicated service level agreement with a range of variables. And I'll give a bit more information on that in the next slide. The next slide. So the private sector considerations, they've got complicated intra-sectoral relationships. It is not a uniform system. It is extremely fragmented. It's complicated relationships. There are informal incentive systems at play. There's fragmented nature of the various components of the private sector, and each with its own governance structures and mechanisms. And we had to navigate across all of those. Lack of a coherent voice and a point of engagement with the private sector, and then lack of trust of government. The next slide then is what our approach has been, is so that the issues mentioned were well known before the pandemic. And we were actually put in a crisis where a response was called for, and it injected urgency into the search for constructive solutions. So a multi-level approach was embarked upon across the National Department, the Western Cape, national specialist bodies, SAMA, hospital groupings under the leadership of the Hospital Association. And that's been at least one connecting point that made it possible for us to speak to hospital groups with one connecting point, but also only up to a point, because we were not allowed to negotiate with an association. That would be against the rules that we received from the national. So although we could engage with the Hospital Association to kind of just sort out things, but if we go into service agreement, it must be by separate hospital. So we also engaged with the 3 largest medical scheme administrators to act as intermediaries when we engage with the private sector players. And also they are experts in administering claims. They've got all the systems in place, they've got the connections, etc. and they were then approached to assist with the administering of the claims from the private providers for the services rendered in terms of the agreement. The next slide. So this gives an idea of all the players in this journey. So to the left, the green boxes speak to the public sector. So you can see there's the regulators, there's the Competition Commission, and they just before this already had a report out, the colleges of medicine, the HPCSA, etc. Just for as an example, I approached the colleges of medicine to say that can you please endorse the clinical guidelines that we've developed, that we just have a bit of more oomph behind this, because we realize it's going to be difficult to get the private colleagues to buy into the guidelines, especially for a uniform approach. Ultimately, they indicated that that's not their role in their brief, which I found interesting. The technical support, the Ministerial Advisory Committee, the MRC, the TRI, Mosaic, clinical governance services, all of those technical support aspects had to come in play. At the national level, Parliament, Cabinet, the Office of the President was on our case, the Department of Health, Treasury, all of those that you can see there, all of them played a role, and somewhere along the line they had to be connected. Provincially, the Department of Health, the Treasury, the MEC for Finance, who ultimately was the person giving approval that we could stand in for the insurance of the doctors. Hospital management, what is not there is the Provincial Cabinet. They were watching as well. To the right, you can see the private sector, the various hospital groups, and you can see that they appointed then attorneys to work with us. And I sat in some of the engagements that Michael Manning had with them. Every T must be crossed, every I must be dotted. Yeah, it was quite an interesting journey. So there are the hospital groups that were there, the provider groups, all of these had separate structures, separately to be connected and called upon and engaged with. Professional bodies at the bottom, you can also see there, they were the professional bodies that we had to engage with. And to the right, technical support from inside actuaries, actuary response group, Unity Health, bankers, funders, and then also at the bottom, the administrative intermediaries. And in the middle, you see the Western Cape Joint Oversight and Governance Committee. Bhavna chaired that session, and that committee had then representatives from the admin intermediaries, the hospital groups, clinical societies, and then us as a province, particular people played there. So the stakeholder engagement has been quite daunting, and to be able to get to a service level agreement in just 3 months has been a massive achievement. And again, credit to all people who really wanted to make this work. The further slide. So our kind of engagement, if you narrow that down, has been the 4 hospital groups, the 3 administrators, and then the clinicians. So all the other colleagues, although they had to be consulted in this journey, when we engaged at the provincial level, the focus was on these to make the operational aspects work. I must say, I personally was very impressed with how the administrators just step into the space to be able to support the department. If we go to the further slide, our contracting period then, so the hospital groups were engaged, the service level agreement was signed with each one of them individually, and we could, although we signed off the service level agreements, the pricing and fee structure was the thing that has to be developed at national level. Although we had offers from some of the groups to say that we will do it for you for this, we said, but this is not a tendering process. We can't do it this way. This is a national function. And it took them quite a long time to get to that point. But once the pricing was agreed to, that helped us to move forward. And then what was also very clear is that you can't predict there's not a recipe for every patient. You had to make provision for some particular needs that patients might have, and to make sure that you get that in. So the admin intermediaries, as I said, they were very useful. We had a service agreement with them. We also then asked each hospital group to indicate with which of the admin intermediaries they wish to work. So we've got to simplify the relationships a bit. Set up the reporting and billing systems that could connect with the public sector system, and then to sign contracts with and pay clinicians. So the admin intermediaries assisted us with that, although we did all the initial engagements. Province provided a budget, just a bulk amount, and said, look, this is it, you've got something to work with, stay within this. And from that, we could calculate with the fees that we got from National, more or less, how many patients would we be able to accommodate within that. And as I've indicated, the Minister of Finance approved that the province would carry the indemnity of the private providers. Some of them indicated they will not sign unless they are indemnified from challenges later on. We established a provincial ethics committee, and the members have been the current ethics committees, and then a rep from the private sector, legal people, people with ethics capabilities. Both Professor Benatar and his son was there, and for us just to make sure that we provide our clinicians with the best support possible, and then also the referral process was outlined. The further slide, okay, we've already said that we did then say the coordinating committee at the provincial level, Bhavna chaired that, we had our business manager there, and we've got the reps of the private hospital groups. The positive outcomes from this engagement has been a deeper understanding of the complexities, levers and mechanisms of engagement. We could work out how, we actually got such a lot of insight in how the private sector worked, and that really will stand us in good stead going forward. Improved relationships, improved cohesion, collaboration, and also willingness. I think the trust relationship has improved over time. The engagement resulted in an operating model and a contracting mechanism with joint oversight. We worked out what will be the mechanism for that. Our model was adopted by National and offered to the other provinces. And then once we had the agreement and the fees was determined, then a strong cooperation followed. A few patients were referred from the public sector in the first wave. A total of 4 was referred, and it was largely to test the system. It was like dummy runs, just to see whether the system worked. And in the second wave, 10 patients were referred. At this stage, there were also requests from the private sector to refer patients to us in the second wave because they were also overwhelmed. Yet we knew that the system would be working. The next slide, I think Bhavna is going to handle this one. Yes, Bhavna, over to you.
Good afternoon, everybody. I just wanted to say hi, but I'll switch my camera off now. So I think in taking this forward, as healthcare practitioners, we base everything that we do on ethical considerations. And similarly, we needed to use this approach in the interactions with private and in drafting these agreements. So given the varied complexities in the private sector, for example, we were dealing with hospital groups, while the clinicians were independent practitioners and not necessarily affiliated to the hospital groups. And both the hospitals and the individual clinicians, their focus is on revenue. They had a lot of mistrust in government, etc. So we needed to find a way to build those relationships. And we use the ethical foundational principles as a means of ensuring that in the pandemic, all patients, irrespective of whether they were public or private, were treated in the same way, that we use the same clinical treatment guidelines and tools for decision making, especially, for example, when it came to decisions about end of life or when to palliate or when to perform certain procedures, etc. So again, our Western Cape clinicians came to the fore and led the way, and they approached their respective clinical societies and actually developed these clinical guidelines, both, for critical care, for general medicine, and for the emergency medical services. And Our clinicians led these discussions at a national level, and these guidelines were then adopted by the societies, which gave us a lot of leeway as the Western Cape, because now we had a document that could be used throughout the country. And in addition, the palliative care group also developed guidelines for supportive care. So the next slide, please. And when we look at ethical principles, I think apart from adhering to the principles of just listening and respecting people's opinions, I think when it comes to the ethical principles, we harped on five main values. And the one I think that stood out was about being truthful. And the way that we did this is by being transparent about everything that we wanted, why we wanted it, how we wanted it to be done. And we listened and respected opinions at the same time. And then, in healthcare, you can't function without the beneficence and the non-maleficence, but also we had to ensure justice. And the justice was about the distributive justice and the social justice, because we had to ensure equal access to everybody that needed care, and we had to ensure that everybody was treated equally, fairly, and impartially. And then the fifth principle we used was obviously about autonomy and informed consent, and this applied to both patient care and to clinicians. So if clinicians weren't willing to participate in our agreements, that was fine. Some of the clinicians offered to perform the service pro bono. So there were various arrangements that had to be made in that regard. The next slide. And then this was one of the reasons why we set up the Provincial Ethics Committee, which was actually an independent committee, so that the private sector didn't feel that we were running the show. And we ensured that it was a non-medical independent person who led the committee. Other members were representatives from the province as well as from the private sector. There was also a palliative care expert and a community member on the committee. And their role was really to oversee the clinical aspects or the ethical aspects related to the relationship, if there were any issues that arose from the clinicians or the patients or the families. Next slide. In this map, really just wanted to show the distribution of public to private facilities. So the red squares are public facilities and the orange circles are private facilities. And if you look at where the orange circles are concentrated in the metro area, you've got small dots, one in Knysna, one in George, one in Worcester. So the bigger sort of towns have small private facilities, but most were concentrated in the metro. So again, our focus was in the metro, but we couldn't ignore that the rural areas also needed access to such an agreement. It was just difficult to use the smaller facilities because they obviously had very little capacity. All right, and I think the last slide. Beth, would you like to take over again?
Thanks, Bhavna. Yeah, thank you very much for that. So key lessons, we just lifted out a few of them. So the principle that healthcare is not a commodity and cannot be left to the marketplace needs to be explicitly endorsed. It does appear that that we do still find that politicians particularly struggle with this factor, and very often even the principle of care that must be prioritized for those that can benefit the most. Is something that doesn't sit easy with many people, and we need to get that explicitly endorsed. The private sector is highly fragmented and undergoverned. The private doctors are not accountable to the facility, as Bhavna has also indicated. So it is vital for us as a country to establish a compelling unifying vision, a value system and policy related to the private health sector that everybody is willing to support. And this will help to build the trust relationship. We know that we have to do some things different going forward, and this could be one way of starting there. There is a need to strengthen the public sector stewardship across the country, support infrastructure and technological system capability at both national and provincial levels. The HMI, the Health Market Inquiry, identified structural impediments related to the private sector. The private colleagues very often say, we want to do things more efficiently, we want to do things differently, but the bodies that rule over us is limiting that aspect. So perhaps we need to, and it's not clear who is taking the lead on taking forward the HMI recommendations. And I think we're missing a great opportunity if we don't go there. And then national and provincial stewardship roles are complementary. We got it very clear from this experience. And there's a need for structures, mechanisms, and processes that will strengthen strategic contracting or purchasing at both national and provincial levels. I think that's the last slide. Thank you. Gitesh, you can just check. Yes, thank you very much. And then the quote there from Peter Drucker: the greatest danger in times of turbulence is not the turbulence itself, but to act yesterday's logic. Thank you very much.
Thank you very much for that presentation. I think it's really an important issue, and I decided to let you really go in depth to talk about them. And for me, the summary, your first point about healthcare not being like any other commodity is something that really is key that we need to keep in mind, especially when we engage the private sector. Without trying to take time out for people who are, I'm sure, very eager to comment or ask questions, I will want to quickly open up the floor. I see there is a comment in the chat box, but before I read that, I want to be sure no one is raising his or her hand. Please indicate by raising hands. I will let you in. Okay, they started coming in. Leslie, please go.
Thanks so much, Beth. It was a really great presentation, and thanks, Bhavna. The fact that private providers are not accountable to any structures or facilities is a real issue, because it limits how the private sector can be stewarded. So if the public sector is going to steward the entire health, the government has to do it. One of the reasons why if the health professionals can't address dual loyalties has made it impossible for private providers to be employed by hospital groups. So they try to pick it up and make them independent, but that's actually not very good for the health system. So I wonder if you can just comment on how you think government is going to be able to steward the whole health system when you have all these atomized private providers, and what should be done about that.
Please go ahead, Beth or Bhavna, whoever.
Thank you very much, Leslie, for that question. And I think that's also the question that we have, is that the Health Market Inquiry report came out a few years ago already, and this exact matter was raised. Yet it does appear that the leadership will have to come from the national level. And yet I think there is not yet clarity about how that will be handled. The question is there something that we can do at the provincial level? Can you say that, this is not only a national problem, this is also a provincial problem? Is there something that we should be doing differently and start energizing here to get going? I think the fact that all the private sector colleagues have national offices, and it's easy to disengage if you are not positioned at a provincial level, that will make that option quite difficult. So hopefully the experience of COVID, the difficulty of contracting, the fact that they are so fragmented, and the fact that ultimately the financing system in the country need to be relooked at. Hopefully those things will start changing the way that they are governed, because looking only at the financing will not help. You have to look at the governance, and actually there is legislation in place, but it's not yet, the execution thereof is challenging. I hope this helps.
Great. I see. I'm sure the questions Leslie asked, okay, are quite different from what was contained in the chat box. But I see also that Beth responded by saying thanks. I guess it's sorted. There is also a question here from Steve Reed. Let's see, fascinating presentation. Thanks, Beth. What was the experience in the second wave when the private sector needed beds in the public sector? Do you want to go, Beth? Beth, sorry.
Thank you very much. I think I'm going to ask Bhavna to perhaps respond to that. At that time, I was not that involved anymore. So perhaps Bhavna, you can help out there.
Yeah. Thank you, Beth. So I think with the second wave, we were a lot more prepared. With the first wave, we only managed to finalize the agreements fairly late during the first wave. So by the time we started using the private beds, we were on the downswing of the curve. So when we came to the second wave, we started the engagements with private early on. And we actually ended up referring 10 patients to them, but it was challenging in that they were also quite full to capacity. The ICU beds were full, the hospital beds were full. So, there were only a few hospitals that we could send to, and the process that we followed allowed us to sort of assess this through our emergency medical services and our bed bureau. But we had to just do what we could, and between public and private, we managed to share wherever there was capacity available. They never ended up sending patients to us, but it was more a public to private transfer. Thank you.
Great. Let's see if there are further questions there. Steve, do you want to follow up, or is that okay? You're free to let me know. I see we have a question. Okay, response from Beth there. And Cynthia is saying, very informative presentation, thank you. How do we take this experience of engaging with the private sector for NHI? In a context of low resources in the public sector? Who wants to go?
So thanks for that. So for the past 14 years, the department had what we call a public-private health forum that's chaired by the Provincial MEC, the Provincial Minister for Health, and then from various perspectives, we engage with the private sector, whether it's equipment or services or hospitals or mortuaries or whatever the case might be. So we do have a functional mechanism that has been there. Yet, at those sessions, we had actually a few times intense discussions on NHI. The fact that there is so much uncertainty at the national, across the country about NHI, because the proposals seems to be very complicated. Yet the fact that we need to build relationships, that we need to build trust, that we need to start working, build on what we've explored here and say, what does it mean for us going forward? The fact that we need each other, I think that should be the foundation of, let's make this work. Let us put a model together in one province, and let's see, whether we can work out something. I don't think we should sit back and not take action. Thank you.
Great. I see another question or comment. Let me read it, and I know what it is. From Leslie, I suspect that there are legislative impediments that need to be undone to enable better stewardship of the private sector. The question is whether either the national or the private sector are looking at what needs to be done, or to look at this in general. That's a question there from Leslie. She wants to go.
So, John, I've just responded in the chat, but, my feeling is it should be led both by the National Department and the Health Professions Council, because the private clinicians are not answerable to anybody at the moment except to themselves. And I think, this is a huge impediment to us taking healthcare forward the way that we would like to into the future. So there's a lot of work that needs to be done, and I'm not sure how much we can do at the local level without the support of the national government.
John, I support. I definitely support what Bhavna is saying. We did in our kind of learnings and recommendations do put that we need to have just a unifying vision for health in the country, and NHI is not doing that, unfortunately. And how do we get to say that we are here to serve the public for improved health? And that the focus is on the client and not on where, what the current focus is on the money and the budget and the insurance part. So unless we get a unifying vision of where we want to go, especially now, narrow it down to the public-private interface, and really make that working well. But as I say, we could start with that at the provincial level and say, let us work out at the provincial level and see whether it does have a knock-on effect nationally.
Great. I also see Leslie chiming in there that perhaps with new leadership at the HPCSA, things will get better. So hope springs eternal. Great. I see. Okay, no more questions, no hands raised. Please, colleagues, feel free to... Oh, sorry, Gavin. Please go. Your hand is up.
Thanks, Beth and Bhavna, and to your team. I mean, really excellent work and fantastic that you actually got an SLA in place. But I was just looking towards UHC and NHI and the future. And so that even though all that work was done and we got an SLA in place, the actual number of patients you served in the private sector that would not have been without an SLA was very small. So it was a tiny fraction. And even though you got guidelines in place for admission to critical care units, for deciding on palliative care, that these were actually done very differently in the private sector versus the public. And so the ability of public sector patients or nominally public sector patients to access private sector beds was minimal because they filled up their beds so rapidly, and particularly their critical care beds. So the proportion of patients with COVID in the private sector who ended up being treated in critical care was much, much higher than in the public sector, and with no real difference in outcomes, it seems. And so this overutilization of particularly the critical care beds versus the public sector, I just thought, what were your feelings on that? And how does this relate going forward to UHC being achieved? Thanks.
Thank you very much, Gavin. And you're absolutely spot on. What we found is that one of the most difficult conversations has been uniform guidelines, both with the hospital groups, because they couldn't stand up for that. They don't have a choice. It's the doctor visiting the hospital that does the treatment. And the specialist groups also were very, very vocal about this aspect. So hence the recommendation that the fact that there must be a kind of equity in care is something that we need to somehow get stronger across. One of the approaches we followed is that initially National wanted to have separate fees for ICU and for high care, and our recommendation was, which was accepted, rather make it only critical care. If you make ICU a higher fee than high care, all the patients will end up in ICU, and that would be the price demanded. So rather make one fee and then try to get a better, affordable and equitable healthcare as one of the strategies. But you are absolutely right. I think going forward in terms of UHC and really make sure what have we learned in this space, and how can one really navigate. I think a lot of discussions is required, and I think a discussion like this today is helpful in start mapping some strategies that we can take forward.
Great. I've got two questions here, one from Virginia. She introduced what she calls a conundrum, that we supported cases who tested positive in the private sector, or about half of the cases were tested in the private sector, but we would need them to have access to platforms such as SPV to be part of contract tracing process. So she is asking if there are any comments on this.
Sorry, John, can I just elaborate on that one? I'm talking about GPs who sent their private cases to get tested, and then we landed up by having to do the case and contact tracing part of that whole process. Some of them were quite keen to get involved in case and contact tracing, but we couldn't give them access to our databases in order for them to do that. Some of them were really super keen to get involved in this kind of support work, but we couldn't give them access. And so that will become a conundrum. That was a conundrum. We landed up by doing the private sector cases and supporting them for contact tracing, but and they couldn't help us in that way. Thanks.
John, I noticed Chris Phillips is in the group. Perhaps you can answer that, because that's more a technical question. Although we focus today only on inpatient contracting, we also contracted with the ambulance services, and we also contracted with private GPs, but the private GPs were largely appointment at a sessional basis. And what we did find is many of the GPs are kind of in the high vulnerability age group, and they ultimately opted, there's a small number who ultimately opted to make themselves available. But perhaps Chris can help us with responding to this one.
Thanks, Beth, and hi, colleagues. So I mean, we don't have too much of time, but I think let's just accept the principle that information systems and their interoperability between public and private sector is also a key enabler or inhibitor to collaboration going forward, whether it's at the primary healthcare level or whether it's at the hospital level, and that also proved quite challenging. So I accept Virginia's point, but I suspect underlying Virginia's point is also there might be other issues, and not just the fact that they had access or didn't have access to SPV. There might be other issues about willingness to do contact tracing, etc. But I think that would be my short response to that. Thanks, colleagues.
Great. I'll take this last question because of time from Lucy. And Lucy is asking, perhaps part of stewardship nationally and provincially is to create a narrative and normative environment that supports regulation. As legal regulation needs enforcement, and enforcement needs wider commitment and wider support. Establishing a focus on patients with non-profit vital, establishing a focus on patients, not profit. I guess just trying to say focus on patients, not necessarily profit, is vital within this narrative or discourse. Who wants to go?
John, I think Lucy is absolutely spot on, and it links to the proposal that we are making, is that in national leadership, there must be guidance to really get that narrative and normative environment to take forward, to really unpack what can be done to make it easier for the private sector to be more efficient, and also to be able to contribute to the public sector, and the other way around. And what are the impediments in the current rules and regulations? But then also, for me, and I think that's also where she's coming up, the issue of stewardship. There is definitely a big challenge in stewardship of the whole system, but in particularly also the private sector. So I fully support what Lucy is saying.
Great. And then we have a very interesting vignette from Leslie. In interest of time, I will not be able to read that. Sorry, Leslie. I hope that's okay. But you're free to take a look at it. And there are a couple of other comments in the box. I acknowledge them, but for interest of time, we would have to wrap up. many people have other things to get onto. At this stage, I really want to, on behalf of the head of the department, thank the two very distinguished presenters who have given us their time and come to talk to us about this very vital and important aspect. Especially in the context of what we are dealing with now. So we want to thank you, Beth, and we also thank you, Bhavna, and also to the wider team, Jitesh, Judith, and Michael. So we thank all of you for giving us this very wonderful presentation, and we wish everyone a happy day further. Bye-bye. Thanks.